This is Patrick's case. I'm Rhys Bowman, the presenter. Respiratory symptoms are common symptoms of lung and heart conditions. The main factors are cigarette smoking and age. Long-term cigarette smoking in Patrick's case has led to the respiratory symptoms such as dyspnea, regular coughs, which have both worsened the severity of his left-sided heart failure and chronic obstructive pulmonary disease. Despite Patrick not having smoked for the last several years, it has still resulted in irreversible damage and reduced lung function. As lung capacity declines with age, Patrick may have developed additional respiratory symptoms and a more severe COPD class. Patrick is more likely to contract an acute respiratory infection since he has a history of heart failure and COPD. Patrick's heart rate is higher than that of a normal adult. The factors which have increased the heart rate are as follows: history of chronic cigarette smoking, high blood pressure, an advanced age group, android obesity, and a lack of physical activity and higher cholesterol levels. In this case, smoking increases the heart rate by tightening major arteries and causes abnormal heart rhythms. Nicotine in cigarettes causes the constriction or narrowing of veins and arteries, causing the heart to work harder than usual. This creates greater resistance for blood to circulate around the body, therefore limiting the amount of blood flow to vital organs. The constricted blood vessels decreases the amount of oxygen and nutrients to the cells and inhibits normal cellular function. In order to meet the demands for more oxygen, the heart rate increases, which leads to the stiffening or a decreased elasticity of blood vessels, making it difficult to pump blood to his peripheries. This change in the structure and function of blood vessels can cause muscular changes to the heart and furthermore increases systolic and diastolic blood pressure. Secondly, Patrick's centralized obesity causes his heart to work harder again because the sheer body weight restricts the blood flow through the arteries and veins. In this case, the patient is obese and the weight is more than the body can sustain. In overweight individuals, the heart again has to compensate to provide adequate circulation, creating a greater blood pressure and associated risks. COPD is a progressive disease that makes breathing difficult. It causes coughing, wheezing, shortness of breath, and chest tightness. In this case, cigarette smoking is a major cause of COPD, which results in less airflow in and out of the airway because the airways and air sacs lose their elastic quality. The fibers in between many of the alveolar sacs are disbanded, forcing the point of gas exchange to become inflamed. The airways produce more mucus and become clogged, and the mucociliary escalator is also compromised. As an obstructive respiratory disease, it causes greater difficulty to exhale. This lung damage prevents the lungs from completely emptying and results in stagnant air being retained in the lungs. It is possible that Patrick's ventilation would be more comfortable at a resting stage, though in an active stage, each breath is coming in before all of the air from the last breath is exhaled, thus causing shortness of breath and impaired oxygenation. Left-sided heart failure is caused by many risk factors such as advanced age, abnormal heart rate, obesity, high blood pressure, diabetes, and coronary heart disease. The presentation of shortness of breath, fluid retention causing leg swelling, sudden weight gain, and chronic coughing are all considered symptoms of left-sided heart failure. These symptoms cause the heart to pump irregularly, which promotes a rapid heart rate, high blood pressure, and less blood flow to the legs and peripheral tissue. However, COPD is not directly related to left-sided heart failure, though these two conditions can exacerbate each other. When blood is not properly oxygenated due to COPD, extra stress is placed on the heart, worsening the symptoms of left-sided heart failure. Conversely, excess fluid in the lungs from left-sided heart failure can make breathing more difficult for someone with COPD. COPD and heart failure are different conditions, but both cause shortness of breath on exertion. These are both complementary to the decline of cardiopulmonary efficacy, though Patrick is expected to maintain respiratory function at rest, whereas on exertion will have a decline in his condition due to hypoxemia. The normal blood flow of the heart comes from the heart comes to the heart from the body through the veins into the right atrium and then goes into the right ventricle. The right ventricle then contracts, pumping the blood from the heart to the lungs for oxygenation. Right-sided heart failure, in the majority of cases, eventuates because of left-sided heart failure. This is due to the left ventricle failing. It raises ventricular blood pressure, and as a result, there is a backflow into the lungs. It will become harder for the right ventricle to pump the returning blood through the lungs again, eventually damaging the right side of the heart. The right ventricle then proceeds to expand and has reduced contractility, causing the blood flow back up into the veins, which is also called right-sided backward flow of blood. This results in inflammation or congestion in the legs, ankles, and inflammation within the stomach, the ascites, the gastrointestinal tract, and liver. In Patrick's case, the main reason for right-sided heart failure would be due to his left-sided heart failure, but there are more factors which contribute to the development of RHF. As he has history of myocardial infarction to a branch in his left coronary artery, he is still at greater risk of having another MI to his right side as well. Being a smoker for almost 40 years, which has led to chronic lung disease, there is yet another heightened risk of pulmonary edema, pulmonary hypertension, which then goes on to exacerbate his high blood pressure and will cause the pulmonary arteries to increase the burden back onto the right ventricle. Without treatment, this will cause the right ventricle to fail with future pathologies. Patrick's elevated serum potassium and sodium levels are to suggest the venous return toward the kidneys is limited. The kidneys are not capable of excreting these electrolytes properly, and then eventuates into fluid retention as the fluid is following a concentration gradient. This allows the fluid to seep into his peripheral vasculature, resulting in the edema. His hemoglobin is reduced also from his limited circulating blood to his kidneys and is preventing the production of erythropoietin and furthermore new red blood cells. His heart is having to work harder to pump more oxygen around the blood. With his ventilation perfusion mismatch, it is yet another pernicious cycle. This will continue into the progression of anemia and greater malaise. His blood glucose and cholesterol are negatively impacting his coronary health as they are all elevated. He may already be suffering from diabetes mellitus, which is yet another risk factor towards coronary heart disease. Whether it be pathologically impaired metabolism or just at this point in time, it is imperative to maintain his healthy levels of LDLs and VGLs for the betterment of his condition. His neurovascular concerns with peripheral edema may afflict his sensory acuity in his lower limbs. His afflicted gait will prevent the skeletal muscle pump from alleviating this pressure. This can have a greater incidence of pressure injuries and sites for infection and go unnoticed by Patrick as there is a limited sensation. His impaired ventilation and lowered serum hemoglobin will result in hypoxemia, which can lead to lowered levels of consciousness and syncope. His risk of myocardial infarction and stroke is in an absolute high, as his average blood glucose, blood pressure, cholesterol, and comorbidities of COPD, LHF, obesity, and being an ex-smoker all point towards a high risk of ensuing severe neurological pathologies. A blood test for serum brain natriuretic peptide is a critical step in investigating the extent of COPD and heart failure. This peptide is produced by the heart blood vessels and is an accurate indicator of the progression of his disease. We would expect a high level of BMP, anywhere between 100 and 400 picograms per milliliter, as this is expected in a pathological state. This will require immediate treatment. This blood test would allow for greater accuracy in understanding Patrick's LHF and how close he is from suffering from RHF and the effects of his concomitant condition. Patrick's case is definitely one with rife with comorbidities that interplay with one another. A clinician would now be able to begin to address his condition with greater knowledge of pathophysiological processes.